Welcome to the Deep Dive. Today, we're tackling a really big shift in medicine, how we handle strokes, specifically the severe ones caused by large vessel occlusion.
That's right. We're drawing from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, specifically the chapter on endovascular management of LVO.
And our mission today is really to unpack this revolution, how mechanical thrombectomy and, well, just getting better at picking the right patients has completely changed the game for severe stroke treatment.
Exactly. We want to understand how we identify and treat these major blockages in the brain's arteries.
Okay, so let's jump right in. An LVO stroke. It's a massive emergency, right? Decisions have to be fast, sometimes with not a lot of info up front.
Absolutely. Time is critical. The first thing really is assessing how bad the stroke is.
And how's that done? What's the standard?
That's where the NIH Stroke Scale, the NIHSS comes in. It's a standardized way to look at neurological function. Things like consciousness, motor skills,
Yeah.
speech.
11 different things, I think.
Exactly. 11 areas. And you get a score based on how impaired the patient is.
So how does that score, how does it connect to deciding on endovascular therapy, like pulling the clot out?
Generally, a score of 6 or more often means the patient might be a candidate. Though, interestingly, in the big clinical trials that prove this works, the average scores were much higher.
Higher, like how high?
Usually in the 15 to 20 range.
Yeah.
So pretty significant deficits.
Okay, but I've heard there's research now on maybe using it for milder strokes too, below that score of 6.
Yes, that's a really active area. The Endolo trial is looking specifically at that patients with NIHSS scores under 6.
Any results yet? Or just ongoing?
Well, there have been some hints it might be beneficial, but we're really waiting on the full trial data for solid answers. It's still being investigated properly.
Makes sense. So even before the hospital, can paramedics or first responders get a sense if it's one of these big LVOs?
Definitely. That's super important for getting patients to the right place quickly. There are pre-hospital tools for this.
Like what kind of tools?
Things like the Los Angeles Motor Scale, or LAMS, the Cincinnati Scale, CPSS, and the RACE scale. They help predict if it's likely an ELVO, an emergent large vessel occlusion.
So they can bypass a closer, maybe less equipped hospital and go straight to a center that can do the thrombectomy.
Precisely. It's all about rapid triage and saving time.
Okay, patient arrives. Imaging is next, and it's critical, I imagine.
Absolutely crucial. About 15–20% of all strokes are these LVOs, and the workhorse for diagnosis. That's usually CT, angiography, or CTA.
How does CTA work in this case?
You inject contrast dye, do a CT scan, and it lights up the blood vessels in the head and neck. You can literally see the blockage, the clot, that might be the target for thrombectomy.
Quick and effective then. But there are other imaging tools too, right? I've heard of aspects.
Yes, aspects. That stands for Alberta Stroke Program Early CT Score. It's done on the non-contrast CT, the one without dye, usually done first.
Okay, and what does it tell you?
It looks for early signs of damage in the brain tissue, specifically in the area the middle cerebral artery supplies a common spot for LVOs. It's a 10-point scale.
10 is good, 0 is bad.
And is a normal scan, yeah. Lower scores mean more early damage is visible. Generally, a score of 6 or more is considered favorable for thrombectomy.
And lower scores, less than 6.
Lower scores, like below 6, might mean more risk, like bleeding after the procedure and maybe not as good an outcome, though there's research on that too.
Right, you mentioned research. Is that the Tesla trial?
Exactly. The Tesla trial is looking at patients with those lower aspect scores between 2 and 5 to see if thrombectomy might still help them, pushing the boundaries a bit.
And technology is helping speed up aspect scoring too.
Oh, definitely. Automated platforms eSpecs use AI to calculate the score really quickly. Results can pop up on a phone or tablet. It really streamlines things.
Okay, what about perfusion imaging? CTP and MRP, when do they come into play?
Good question. Perfusion imaging, whether CT or MRI-based, helps distinguish between the core tissue that's already died and the penumbra.
The penumbra being the tissue at risk, but potentially salvageable.
Exactly. It's especially helpful when you don't know exactly when the stroke started. Like if someone woke up with symptoms.
Why CTP over MRP sometimes?
CTP, the CT version, is often just easier to slot into the workflow right after the initial CTA. Faster, usually, but MRP provides great detail, too.
Is perfusion imaging used everywhere, routinely?
It varies quite a bit. Some centers use it routinely, others more selectively. Depends on local protocols, physician preference.
And AI is involved here, too.
Yes, automated software like RapidAI can process these perfusion scans incredibly fast, giving you maps of the core and penumbra almost instantly.
Now, you mentioned something called a ghost infarct core. Sounds spooky. What's that?
Yeah. It's an important concept. Very early on, like in the first few hours, perfusion imaging might overestimate the size of the irreversible damaged core.
So it looks worse than it might actually be.
Potentially, yes. It means we need to be a bit cautious about ruling people out based only on perfusion imaging super early, say within the first 6 hours. The tissue might still be recoverable.
Okay, so recapping imaging. CTA finds the clot. Aspects on the non-contrast CT shows early damage. Perfusion helps see core versus penumbra, especially later or with unknown onset.
That's a good summary. And now AI tools like RapidAI and Viz.ai can even detect the LVO automatically on the scans.
Wow, so it flags it for the doctors immediately.
Yeah, speeding up alerts, triage, transfers. It's a big help. And there's even research looking at the clot itself on CT or CTA.
To see what it's made of, maybe?
Sort of, looking at its shape, density, hoping maybe that can guide which thrombectomy technique might work best. But that's still very much investigational.
Got it. Okay, so we found the LVO. What about the clot-busting drug, IV thrombolysis or RTPA? Does that still play a role here?
It does, but maybe a more limited one for these big clots. FARVI-RTPA was approved based on the N90s trial, showing better outcomes if given within 3 hours.
Right, the original clot buster.
Yes. It improved function, though not mortality. Then the ECAS-3 trial looked at extending that window to 4.5 hours.
Did that work as well?
It showed some potential benefit in select patients, but it was less pronounced, and there was a higher risk of bleeding, especially in older patients or those with very severe strokes.
So the 3-hour window is still the main one.
That's the primary FDA-approved window, yes. The 3 to 4.5-hour window is used more cautiously under specific guidelines.
But for these large vessel occlusions, does IVR-TPA often work?
Often not so well. It struggles to dissolve big, dense clots in major arteries like the carotid or the main MCA branch, M1. It might have more success further out in smaller branches like M2, but for the big ones.
That's often not enough.
Exactly. Which leads us directly to needing a mechanical solution.
Endovascular therapy. Mechanical thrombectomy. This is the real revolution, isn't it?
Absolutely. Physically removing the clot, that's the core idea, using devices like stent retrievers or aspiration catheters, or often both together. It's become the standard of care for LVO.
Can you walk us through those two main techniques? Aspiration first.
Sure. Aspiration thrombectomy uses a relatively large, flexible catheter that's navigated up to the clot. Then you apply suction, basically vacuuming the clot out. Lots of different catheter types available now.
Okay, and stent retrievers.
Stent retrievers are like tiny expandable mesh tubes. You deploy the stent across the clot, it embeds into it, traps it within the mesh.
And then you just pull it out?
Carefully, yes. You retract the stent, and hopefully the clot comes with it. Often we use combination approaches.
Like using both at once?
Sort of. Maybe using a balloon guide catheter further back to temporarily stop blood flow, reducing the chance of clot bits breaking off. And maybe using an aspiration catheter right at the clot face while retrieving the stent. It improves the chances of getting everything.
And the evidence for this, it's pretty solid now, right? Thanks to some big trials.
Incredibly solid. There was a wave of landmark randomized trials around 2015, Mr. Clean, Escape, Swift Prime, then later ones like Dawn, Diffuse 3, Aster, DirectMT.
What did they generally show?
Consistently, they showed significantly better functional outcomes for patients who got thrombectomy compared to just medical management, like IVR-TPA alone for LVO. Better chance of living independently.
Did they look at different time windows?
Yes. Initially focused on up to 6 to 8 hours, but trials like Dawn and Diffuse 3 were game changers. They used advanced imaging perfusion mismatch to select patients who could benefit even up to 16 or 24 hours after onset.
So it shifted from just time is brain to tissue is brain too, selecting based on imaging, not just the clock.
Exactly. If there's salvageable brain tissue, a large penumbra and small core, time becomes less rigid. Some trials also compared techniques, like Aster comparing aspiration versus stent retriever first.
And what about giving IVR-TPA before thrombectomy?
That's been studied too, like in DirectMT. The results are a bit complex, but currently giving IVR-TPA first if the patient is eligible and arrives quickly is still common practice in many places, though some are questioning if it's always needed if thrombectomy is done super fast.
Okay. What about angioplasty and stenting during these procedures? Are they common?
Not for the clot removal itself, usually. Angioplasty and stenting are more for underlying blockages, like if the LVO is actually caused by acute plaque rupture and narrowing within the artery wall itself, atherosclerosis. That's less common than clots traveling from the heart, for example.
So mostly thrombectomy for clot removal. Now, the guidelines for who gets thrombectomy, are they keeping up with all this rapid change?
That's a fair point. Guidelines often lag a bit behind the cutting edge. The 2019 SNIS Guidelines Society of Neurointerventional Surgery probably reflect current thinking better.
What do they cover?
They look at time from onset up to 24 hours for anterior circulation LVO in select patients based on Dawn Diffuse 3 criteria. They consider imaging aspect scores, core size on perfusion, location of the clot, definitely ICA, M1, M2, reasonably for posterior circulation too, and stroke severity, typically NIHSS of 6 or more for the front circulation strokes.
It sounds much more nuanced than just a simple time window.
It is. It's about matching the right patient to the right treatment using clinical and imaging data.
And we mentioned trials like Tesla and Endolo are still pushing those boundaries.
Correct. Tesla for larger cores, Endolo for milder strokes. And there are also trials like Swift Direct or Direct Angio, looking at potentially taking patients straight to the angio suite, maybe skipping some steps for speed.
Fascinating. Let's shift gears slightly. Delivering this kind of care requires a specialized setup, right? The team and the hospital.
Absolutely. It's not something just any hospital can do. You need a dedicated neurointerventional team.
Who's on that team typically?
The neurointerventionist could be a specially trained neurologist, neurosurgeon, or radiologist, plus skilled techs, a dedicated nurse, maybe trainees like residents or fellows in bigger centers.
But it's broader than just the procedure team, isn't it?
Oh, yes. You need strong support from stroke neurology, neurosurgery for backup, neurocritical care for post-procedure management. That's why comprehensive stroke centers, CSCs, are so important. They have all those pieces.
And now there are thrombectomy-capable stroke centers too, TSCs.
Right. That's a newer certification for centers that can perform thrombectomy 24/7 but might not meet all the extensive requirements of a full CSC. It expands access.
And the whole system, the stroke system of care, is designed to cut down delays.
Exactly. It's all about coordination. From EMS in the field, recognizing the stroke, using those pre-hospital scales, communicating with the hospital, getting the patient scanned quickly, and getting the team activated.
Are there specific time goals?
Yes, SNIS has targets like door to needle for IV thrombolysis under 30 minutes, door to groin puncture for thrombectomy under 60 minutes, and door to recanalization opening the vessel under 90 minutes. Very ambitious, but crucial.
Communication between EMS and the ER sounds vital then.
Absolutely critical for pre-notification and team activation, shaves off precious minutes.
We're even seeing tech move outside the hospital now with mobile stroke units.
Yes. These are amazing. Specialized ambulances with a CT scanner on board.
A CT scanner in the ambulance.
Yeah. They can do a non-contrast CT, even a CTA sometimes. They carry RTPA. They're staffed with paramedics, nurses, CT techs.
So they can diagnose and even start 5E treatment right there, on the scene or en route.
Precisely. The idea is to start the clock much earlier. Studies show they increase RTPA use and can reduce time to thrombectomy if needed.
So it's like bringing the ER evaluation to the patient.
In a way, yes. It's a very advanced form of pre-hospital triage and early treatment initiation. Connects back to those pre-hospital LVO scales, too, helping decide who needs that level of response.
It seems like technology and system coordination are just constantly improving.
They really are. We're seeing innovative things like GPS tracking apps to coordinate patient transport and team locations. Information tech is definitely going to keep pushing stroke care forward.
Well, this has been incredibly insightful, a real deep dive into how far we've come with treating these severe strokes. If you had to boil it down, what are the biggest takeaways?
I think two main things. First, the incredible impact of mechanical thrombectomy. It's shifted the paradigm for LVO. Second, how crucial patient selection is using advanced imaging and clinical factors to pick who benefits most, even extending treatment windows significantly.
And speed. The constant emphasis on reducing time at every single step.
Absolutely. Rapid evaluation, rapid triage, rapid treatment. That mantra hasn't changed. If anything, it's more important than ever. And the research isn't stopping. We're still refining who is eligible and how to best perform these procedures.
So final thought for our listeners to chew on. With technology like AI and mobile units evolving so fast, what might pre-hospital stroke care look like in, say, the next 10 years? And how could that change outcomes and maybe even access to this kind of advanced care across different communities?
That's the big question, isn't it? Lots to think about there.
Thank you for joining us for this deep dive.